we'll start a little bit more broadly by talking about just really maybe giving a quick overview of the current standard of care in treating muscle-invasive bladder cancer, both surgical, maybe non-surgical approaches as well, and of course systemic therapy options, and then maybe also a quick discussion about basically the opportunity to utilize biomarkers in this setting.
Absolutely, great, yeah. So currently, for muscle-invasive disease, there are two major ways of dealing with the cancer. And that is to take out the bladder and the adjacent lymph nodes with a radical cystectomy, and also a bladder-sparing approach, which involves radiation in combination with chemotherapy. Now, in patients who are getting a planned cystectomy, we have level 1 evidence that giving cisplatin-based therapy is associated with improved overall survival. And this is basically because there are a group of patients who have micrometastatic disease that wouldn't be cured with a cystectomy, right? And so these patients, the ones that are able to eliminate that micrometastatic disease, probably benefit from neoadjuvant therapy.
Yeah.
So I think, the biomarkers are an important, you need those biomarkers here.
Yeah. And then I think this is a good segue to maybe discuss, circulating tumor DNA, and maybe its role in bladder cancer and just in general the concept of MRD in muscle-invasive bladder cancer, which you sort of touched on briefly already.
Right. So, I think, this is a great place to explore this kind of a biomarker, because not everybody has micrometastatic disease. So we truly need to select patients that need this mop-up chemo, because there can only be one thing that happens when you treat patients who don't have disease, and that's you have adverse outcomes and you have mortality that you don't really need. So, in urothelial carcinoma, I would say that we have the benefit that it's a malignancy with a generally aggressive phenotype, because of that reason, there's considerable shedding of DNA in these tumors. And as such, ctDNA has been a really valuable tool, as it has kind of allowed us to sample the genetic makeup of these tumors. But not all ctDNA tests are the same. Back in the day, 4 or 5 years ago, the only ctDNA tests we had were pre-informed panels, basically filled with clinically actionable genes such as FGFR for bladder cancer or BRCA2. And we would simply interrogate these genes and see if these were altered. And sure, if you found an FGFR alteration floating around and the patient had bladder cancer, you're thinking, yeah, maybe this is the bladder cancer, right? But there are new generation of tests that are now coming into the clinic, and these are called molecular residual disease tests. And these are a little bit different from taking that, okay, this is my fixed panel of mutations. And what we do is you're going back and taking the sample of the tumor, probably from the TURBT, then you sequence the whole tumor out without having any bias in what you're about to select, and then identify what are the alterations that are making that tumor what it is. And then you can select out a number of mutations, and then you basically want to select mutations that are not like BRCA2 ideally, because you want those mutations to be agnostic of what the patient is being treated with. You want it to be a marker of disease. So you kind of select based on an algorithm, a set of mutations that are unlikely to change with treatment pressure, that are likely to be present, and then you basically design your own specific NGS panel and then go in and look for those alterations in the blood. So what you have, therefore, is a very sensitive and a very specific marker. And that's why it becomes molecular residual disease. And that's a good way to look for it, in a neoadjuvant population for sure, right? And even the adjuvant.
Yeah, and thank you. Yeah, that is a really excellent overview, and especially how the progress that's happened over the last really just really over the last several years, right? Maybe you could touch on quickly, basically the current or the currently approved indications for the use of liquid biomarkers and circulating tumor DNA specifically in urothelial cancer. Like what settings would you actually use it in?
Yeah. So, this is relatively new approvals, but this is based on some really strong data from the Abacus and IMvigor 010 trial, as well as some data from Christensen. We'll talk about it. But the approval is for monitoring of treatment monitoring in the neoadjuvant setting, and also in the adjuvant setting for recurrence, early detection of recurrence in bladder cancer patients. So you could technically start doing that before neoadjuvant therapy, identify patients who are at high risk, so on and so forth.
Mm-hmm. And what is your current practice for using this biomarker in bladder cancer? Like where do you, like in your practice, where do you send it basically?
Sure. So I use it in that setting actually. So when the patient comes into clinic, I will start once the patient has a TURBT, we'll send out a sample for MRD. And I think, maybe I should also touch upon the evidence behind why we are doing this, and behind the approval. So in the neoadjuvant setting, the data comes from two sources. One is a paper by Christensen and others with Dr. Driscott at the Aarhus University. This was one of
that's in Denmark. Yeah,
that's exactly right. The group up in Denmark who kind of pioneered this test in the clinic, really. So this study ran from like 2013 to 2017. You'd think it's almost 10 years ago now.
Yeah.
They had about 60-something, about 70 patients with muscle-invasive bladder cancer, who essentially, you have the whole natural history on those patients, came into the clinic, got MRD testing done on their tumors, underwent neoadjuvant therapy, then had a cystectomy. All of these patients had a cystectomy. Some were followed during that adjuvant period. Most did not get adjuvant therapy. It wasn't really indicated back then. And then you have recurrences and therapies and their clinical outcomes. And all the while, they're getting MRD done. And what this study showed was that there was a significant percentage of patients, as you would expect, 30-40% of patients who had MRD positivity at the beginning of neoadjuvant therapy. These are likely the patients who would have otherwise recurred down the line. Many of those patients actually cleared their MRD by the time that they reached cystectomy.
Yeah. And this is with treatment or without, or just...
Yes. These patients many of them are getting neoadjuvant therapy. So just like the clinic setting. And it was very interesting because patients who had MRD positivity before neoadjuvant therapy had a hazard of 29 for an eventual recurrence. So they were almost 30 times more likely to have a recurrence. And when you look at the recurrence setting, in this cohort of about 70 patients or so, the test was able to identify correctly each and every recurrence of disease without missing a single one. And it did not identify any recurrences falsely. So there were no false positives. So this is about a 90, 95, I think it was like a 98% sensitive and 100% specific. Excellent operating parameters for this kind of a test.
Yeah.
And so, that's one. And the other data came from IMvigor 010.
Yeah. And remind us just real quick what the IMvigor 10 study was.
Right. So that study was it was a study of adjuvant atezolizumab in patients who had high risk urothelial carcinoma who had undergone cystectomy, right? So by high risk, that they meant patients who have had previous adequate cisplatin exposure continued to have muscle-invasive disease or worse, or patients who otherwise did not have cisplatin exposure, had PT3 disease or worse. And these patients you would think, are going to be really high risk. It turned out about 37% of those patients were positive for MRD.
Yeah.
And what happened?
And before we get into that, it's also worth noting that overall it was a negative trial, right? So atezolizumab versus observation, right? It wasn't placebo controlled. Yeah.
Yes.
Did not show benefit, right? But there was a subset, I think, and you're about to get into that, where I think we can make a difference, right, with adjuvant immunotherapy.
Exactly right, Vadim. Like if we did not know about this MRD biomarker, it would have been thought to be a completely futile trial, that there is no use of doing atezo in these patients, despite having almost a 40% positivity rate for the MRD across the whole population. But when, as you said, when they broke it down by the MRD status, they saw that patients who had disease, basically MRD, had a hazard of 0.5 something, like it's a pretty good hazard, almost as good as SNEVO, and it was statistically significant, although this is a pre-planned exploratory analysis, not powered for conclusive, conclusions rather. But very thought-provoking and hypothesis generating. And the interesting thing was the negative arm. You would think that the hazard, if something, you give water to someone like a placebo, you would expect, oh, it's not going to work, so you're going to have a hazard of 1. But the hazard for progression-free survival and overall survival was more than 1. The hazard was 1.31 at the initial readout and 1.38 at the follow-up readout at EAU. So patients who didn't have disease.
So these are patients with a negative biomarker post-surgery, right? And you're giving them atezolizumab, and they're actually doing worse, right?
And they're doing less. That seems to be the trend. Again, this was a pre-planned, and it's statistically close to significance now as the follow-up continues.